BN2 lúc 25 tuần. Sàng lọc sơ sinh không làm ạ?
Okay, so if you can pop your hand behind your head, please. And when you start to sign, my signature. And thank you for doing something to sign today. Very kind of you. Okay. So I'm going to start the first procedure, which is a RM7C, which is a patient in the third trimester. And I start off the scan and I see the baby in cephalic presentation. And when I see, I open up my sector width, which is max, and I then sweep up to the baby's bottom, and then I sweep from left to right side, confirming with a single live baby on board. So with regard to evaluating the baby's cardiac anatomy, and the first thing I do is I'm going to take down my sector width. So if you look here, my PRS is at frame rate is at 30 hertz. And when I take my sector width down, you will see that my frame rate now jumps up to 52 hertz, maybe more. Then I reduce my depth, and then once I've got my depth reduced, then I can reduce it. So it's exactly the same when I did the scan in the last patient. And I'm now firing at 67 hertz, and in this baby is a very magnified image. The other control which I like to do is I like to go into my supplement use, and I like to select apps and you can map the size. So if I then come down with a make contrast between contrast. So look at the 14th view part. This is the descending aorta, which is to the left of the spine, and this here is the mitral valve, and this is the percussive valve, and this is the moderator valve. So I'm just following the rules of the descending aorta to tell me exactly where everything is. When I look at the baby's heart beating, you can see that there's an intermittent rhythm disturbance. When I look on this, I put an end mode on and get an end mode trace of the baby's heart. And I put the end mode from the right atrium through the left cardiac ventricle. What I'm looking at here is the atrial contractions and the transmission of the atrial contractions. These are the ventricular contractions. So I'm mapping both the atrial and the ventricular contractions on an end mode. I will come back to this in a second. But while the baby is having the ectopic beats, I just want to catch it before it changes. So sometimes the baby goes in and out of cardiac rhythm disturbances. What I'm seeing is in this baby that there are premature, intermittent premature atrial ectopics. And the question is how often or how intermittent? Is it every second beat, third beat, fourth beat, or is it variable? I'll just magnify the image of the heart. And when looking at the rhythm disturbance, you focus on the wall of the right atrium and you focus on the wall of the right ventricle. And when you come across this, then you're comparing the ventricular motion. This here is the right atrial motion, not up here, down here, because it shows the ventricle first. So this is the left ventricular wall here. This is the interventricular septum here, and this is the right atrium down here. So you're looking to see the transmitted pulsations from the ventricle. You're looking at the ventricular motion, and you're looking at the corresponding atrial motion. So the atrial sends off an electrical impulse, and then it goes down to the ventricle, and the ventricle contracts. So from the right atrium to the left ventricle, and this is the best place in terms of where you take your end mode and doing a rhythm disturbance evaluation. But let's start with the anatomy of the heart. And first of all, go to the issue of guidelines. So here I have the stomach, section 1. I have the aorta to the left of the spine. I have the IVC, which is anterior to the right of the spine. And I save that image to file. Then I look at the intrahepatic vein. As I see the intrahepatic vein, it comes into the stomach and then it curves away like a letter J. And then the gallbladder, which is quite small, is here. So it's the correct position of the intrahepatic vein, the IVC, the stomach, it looks normal. That's section 1 of the ISO guidelines. The next section is looking at section 2. So when I mentioned to you the ratio, to calculate cardiac thoracic ratio, can you do that? Cardiac thoracic ratio? Okay, cardiac thoracic, so take the thorax. Okay, so we can take a measurement of the fetal thorax, so take the thoracic circumference Because I think the cardiomegaly is looking at this objectively. Come across on that. Like that. And then I take a measurement of the cardiac circumference. So when I look at that, there's mild cardiac megaly with a rhythm disturbance. So then I take genetic area and I take the cardiac circumference. And as I look here, I look at the ratio of cardiac thoracic ratio. Now the cardiac thoracic ratio is normally about 58%. In some patients it's up to 60, but it's more than 60 when I'd be more worried. Thoracic circumference is 21.6, thoracic circumference is 37. So just save that as well. I get rid of my text. And then when I'm looking at the cardiomegaly, then I ask myself, is there pericardial effusion? As I look at this here, I see that this is this normal amount of fluid around the baby's heart and around the right ventricle. Most pericardial effusions occur around the right ventricle. I see that the apex of the heart is formed by the left ventricle. This is the right ventricle over here, this is the left ventricle here. The descending aorta tells me that this is the left atrium. You see the heart now is returning to moments of normal heart rhythm to block. So it's an intermittent rhythm. Babies with intermittent cardiac rhythm disturbances have a much better prognosis than those who are sustained. So if we look across here, this is the left descending aorta, pulmonary veins, left atrium, left ventricle, now back to normal heart rhythm, right ventricle and right atrium. When I look in slow motion, I see the position of the right atrial ventricular valve. This is the septal leaflet, which is closer to the apex than the mitral leaflet. So the normal offset. This here is the ventricular septum, and this is the atrium primum. The atrium primum was missing in the last baby. It's present and normal in this baby. When I look at the roof of the atrium, I see that this here is the atrium. There are three components of the atrium septum. This component here, which is the coming up from the atrium of the atrium primum, coming down the roof is secundum, and then between it here is the foramen ovale. The foramen ovale should balloon from the right to the left side of the heart. And if you magnify the image of this, you can see the foramen ovale ballooning. So when I do this, if I increase my dynamic contrast, remove my text, you can see the very fine motion of the foramen ovale here. Primum, the secundum, and the ovale, and you can see if we rewind that, the ovale should be less than 50% across. So if we take that this is 50% here, this is a half, and this is a half on the opposite side, then the position of the baby foramen ovale here is normal. It doesn't go across. In some babies, you find that foramen ovale balloons more than 50% across, and we call it foramen ovale aneurysm. When I look at the left ventricle, I can see the very normal entrance of the pulmonary veins entering here, and the pulmonary veins entering here. So I have a normal position of the pulmonary veins on both sides. When I look coming down to the left ventricle, you can see the left ventricle is smooth in comparison to the right ventricle. So this is the appearance of the left ventricle, which is smooth, and this is pyramidal in shape and it's rough, irregular. This is how you pick up congenitally corrected transposition because the morphology of the ventricles is switched. And I can see that when I look at this ventricle, that this is a moderated band coming across from this right ventricle and it looks normal. When I look at the left ventricular outflow tract, I then will take my transducer to get the next section evaluating the baby's heart, and I magnify the image showing the left ventricular outflow tract. So I look here that this is the aortic valve. I use simulated review and I see that the aortic valve disappears completely, and it does. So it's a normal aorta, normal continuity of the left ventricular outflow tract with the interventricular septum. A normal continuity, normal caliber, and normal aortic valve. And then the next section I look at is the pulmonary artery. When I look at the pulmonary artery, I'm seeing the free wall of the right ventricle. So this is the right ventricular wall here, and this is the pulmonary valve here. When I'm looking at the pulmonary valve, I'm looking to see that the pulmonary valve opens and closes during ventricular systole. And there it's open, and there it's closed. And I look to see if there's any thickening of the valve. I look to see that the pulmonary artery is larger than the aorta, which is larger than the SCC. So the normal order of size, 3, 2, 1. And I say that to definitive review. When I come up to looking at the branching of the pulmonary artery, this is the main pulmonary artery here, coming out of the right ventricle, and then here, it goes behind the aorta. Remember, the right pulmonary artery should always be smaller than the aorta, and this is the arterial duct immediately here. So this is it. Once the pulmonary artery gives off the left and right branch, so this is the right branch coming in here, and then I do not show it to you here, but then your left pulmonary artery comes in here, and then this vessel from here to here is your arterial duct. So the arterial duct is quite a long vessel, and it's important to see that you see flow in the arterial duct. So that's just showing you the normal anatomy of those vessels. And then this shows you the three vessels tracheal view. So in the three vessels tracheal view, you will see here that this is the duct, aorta, trachea, and SCCs. And because you know that this is the trachea, you know the vessel that is closest to the trachea is the aorta. So now I want to look at this baby's heart in colour. I want to see the any tricuspid valve regurgitation. I also want to make sure that the baby does not have the dilated coronary sinus, because the coronary sinus just looks a little bit prominent. So I need to make sure that this baby does not have anomalous pulmonary venous return, and this baby does not have a persistent left SCC. One of the features of anomalous pulmonary venous return is you will see the right ventricle is larger than the left. But in this baby, I think the left ventricle is actually larger than the right. So that makes anomalous pulmonary venous return unlikely. So I'm just going to stop reading for a second. We were normally. Well done. So again, I can see the baby. I just wanted to get a long skinny loop, just demonstrating the cardiac rhythm. And I can see that the baby goes intermittently in and out of the rhythm disturbance. Mostly the baby has got an irregular, abnormal rhythm, and then has an intermittent episode of normal rhythm. As I say, these babies carry a better prognosis if it's intermittent. I'm going to do one more loop. Stop reading. So it goes for about 10 beats, and then it reverts into a cardiac rhythm back again. So it's about every 10 to 15 beats that it goes into this rhythm disturbance of bradycardia and then back to normal rhythm. Okay, you need to look now at colour. So first of all, I've now changed to a cardiac preset. So I now go to a 4-chamber view of the heart, magnify the image. And I'm looking at my PRF is at 37. The baby is 31 weeks gestation, this is too low. So I put my PRF up to 68, and now I've got a correct setting. I'm going to increase my dynamic range, and then I'm going to magnify my image. And as I do so, then I can see that there is a regurgitation, not a huge regurgitation jet, but I can see there's a regurgitation jet. And when you're looking at the regurgitation jet, you need to go sweep across the atrium to see the regurgitation jet. But it's very minor. So this baby is told that tricuspid regurgitation. It may have tricuspid regurgitation when it's in the rhythm disturbance or outside the rhythm disturbance. So it's important just to come back and look at that. But if I look at this, I would call this trivial regurgitation. You come back and you see the intermittent episode of seeing tiny jets of regurgitation that are across this right atrial valve, which I'm not really worried about in this baby. It's very minor, very trivial. You can do a stick volume operation, and we'll do it in a second. So I'll take the 4D volume of this, 15 seconds. Is the patient feeling lightheaded? Is she feeling lightheaded? Can you please check? Is the patient okay? Is okay? She's okay? Okay, thank you. Sometimes in patients, you're doing a live scan for a long time, lying on the back, they can just get lightheaded. So if you look here on the rendered image, you have a nice demonstration of the rendered image of the baby's 3-vessel tracheal view. So bring that down to 50% nasal rhythm. And you have here the main pulmonary artery coming out of the right cardiac ventricle, left starting to kick, left cardiac ventricle, and this is the transverse aorta. You can see that nice and animal flow. I save that volume to the hard drive as a P2. I get rid of my rendered image, and I just select my A plane. And when I'm looking for regurgitation, this is what I do. I go to the A plane. Once I'm in the A plane, I then take my reference dot, and I place my reference dot in the middle of the ventricular septum. And then I sweep around the y-axis to make sure that I have a perfect symmetry of the baby's heart. And then I translate through the volume to see if I can see any evidence of regurgitation yet. And then I turn on DCI. Once I'm on DCI, I then go to a sub-menu, go to turn off sepia, I prefer ice setting. And then I translate through the volume looking for any evidence of regurgitation. But I feel that this baby has normal flow. I see the left ventricular outflow tract, and I see that there's turbulence in the left ventricular outflow tract. But I think the reason this baby shows turbulence is not because the baby has aortic stenosis, but because the baby's PRF is too low. But I need to check this, and I also do a pulse Doppler just to make sure. And then I come across, and I see the way that the first vessel that leaves the heart is the aorta, and then if you go higher, then the pulmonary artery comes over, and the pulmonary artery crosses over the aorta. It's very important to see that as part of a normal examination. Okay, good. So we just go back to the live scan, go back to checking that there's no aortic stenosis. When I'm looking at the left ventricular outflow tract, I turn on color. I'm going to now reduce my radius, and I'm going to increase my PRF at 57, patient 31 weeks. And now my PRF is at 68, and now it's at 86. And now you see, once I get to 86, I have a much better definition of the left ventricular outflow tract. I can see in the left stream the way the aortic valve opens and closes normally, and I can see on the right side, I can see that I have laminar flow across the baby's aortic valve. If I was suspicious about the baby having aortic stenosis, then I'll place my pulse Doppler gauge, I'll open it wide, and I'll just take off color for a second. I place it wide, and then I put angle correct, so the pulse Doppler gauge goes exactly over the aortic valve. We will hear the rhythm disturbance when we do this. Getting a slightly elevated just over 120, so when I get something like that, I want to know is it real or not. So my next step is I'm going to change my transducer, and I'm going to go to C2 to 9. If I ever suspect that there's a valvular disturbance, there's a pulmonary valve, I then look at the other valve, and I quickly compare the velocity from one valve to another. So I open it, and I angle correct it so it's distal to the valve, not near, but like the first semester. So the velocity of this baby are in the upper range of normal. So we do a Z-score, generic max systolic velocity for a pulmonary Vmax. So if I look at the pulmonary Vmax velocity, it's just at the upper range of normal, so 98 centimeters. And so this baby's velocities are normal, I'm not worried. And now I'm going to compare, and you can compare one to the other directly. So similarly, the velocities, when I compare one to the other pulmonary, I go to pulmonary, to the aorta. And the baby's got aortic stenosis. You can hear the normal velocity, and when you've got velocity, it's obstructed here. You can hear the stenotic velocity in the baby who's got pulmonary aortic stenosis. I think this baby's velocities are at the upper range of normal, but they are normal. So, in summary, we've done these 4-section analysis. We've confirmed that the aorta is to the left of the spine, that the IVC is anterior to the right. We confirmed that the intrahepatic vein comes in and sweeps away. and we've shown that the gallbladder is on the opposite side. So that's the first section. And then we've updated it, and we show that the fourth chamber view of heart is cardiomegaly. There's no pericardial effusion. You see the pulmonary veins empty normally, normal chambers, normal AV valves, normal priming, normal foramen ovale. And then I go next to looking at the left ventricular tract. And then next I go to looking at the right ventricular tract and show the right ventricle, pulmonary valve, aorta, SEC, right pulmonary artery, and then after the 3 vesical views. And you can repeat the exact same exercise. You can do that with colour, and do the whole thing, the aorta and IVC, and then with PRF. You're demonstrating your aorta, your IVC. You're demonstrating your intrahepatic vein coming in and sweeping away from the stomach. If there's not a persistent right umbilical vein. And once you've got the image of that in the aorta and IVC, you then increase your PRF to 76 centimeters a second. In the fourth chamber, you show the cardiomegaly. You see the no purpose of valve regurgitation, with normal fill of the ventricles, equal volume of flow across the right and left ventricles. You then look at the left ventricular aortic tract. You show the laminar flow across the aortic valve, and you see that the wall of the aorta is continuous with the interventricular septum, that's normal. And then your last section that you take is that you show the pulmonary artery, the aorta, and the SEC, the 3 vessel view, and then the 3 vessel tracheal view. And once you've got that demonstration of the 3 vessel tracheal view, you know that the anatomy of the heart of the baby is normal. The only problem the baby has is an intermittent rhythm disturbance, which I'm not too worried about, but I would involve a pediatric cardiologist. In a baby who's got a cardiac disturbance, it's important just to make sure that there's not any evidence of hydroxygenase. And also in some babies, when you look at the transverse aortic arch, you will see reversal of flow. You can just look here and see a little bit of reversal of flow. This frequently happens in a baby who's hiccuping, or a baby who's breathing, and I can feel the baby hiccuping, and I can feel the movement of breathing. This is a normal finding. This is not an obstructed heart lesion. If it was an obstructed heart lesion, I would find that the aorta would be small. Remember, that's the cluster of the tract is always the transverse aortic arch. Yep.